of inherited disorders which are bilaterally symmetrical, slowly progressive, and have a genetic basis to it. The treatment we know is mainly symptomatic. We'd give contact lenses, lubrication, sometimes foot therapeutic keratectomy, or even transplants in extreme cases. However, considering the basis is genetic mutations, there is no scope yet to alter the disease process. Let us have a look at keratoplasty in corneal dystrophies. Well, many of you may not be aware that Fuchs dystrophy was the commonest indication. 39% of all corneal transplants performed globally in the year 2012. In another study from South India in 2017 and 18, dystrophies were the indication of 500 transplants in one center alone. But we know that with keratoplasty, the visual rehabilitation is unpredictable. You have graft, suture-related complications. And the most important thing where dystrophies are concerned is recurrence of dystrophies. So is it time? Do we need to look at dystrophies from a different angle? Well, we have another very common disease, that is keratoconus, and another leading cause of transplants, that is, which has always been categorized. If you see, this is a screenshot from a textbook. It's always been put in the bracket of non-inflammatory disorders. It also has two significant treatment modalities, collagen cross-linking and transplants, which are both surgical. However, our previous work on tear biomarkers has proved that keratoconus is indeed driven by an inflammatory pathway, and we found an altered tear inflammatory profile in keratoconus. So this brought us to our research question, that if we need to look at dystrophies differently, can dystrophies also be driven by an alternate pathway? This brings us to the purpose of our study, is to study the tear, levels of tear-soluble factors in tears of patients from corneal dystrophy. So it was a cross-sectional study with prior institutional ethics committee approval. We included patients which were clinically diagnosed with confirmed corneal dystrophy and excluded if any of them had undergone any prior surgery, if any of them were on any medications or any signs of active inflammation, etc. What we did is we used 48 eyes of cases diagnosed with corneal dystrophy and 18 healthy eyes as controls. We included patients of epithelial corneal dystrophy, lattice, macular, granular, and Fuchs corneal dystrophy. All these patients, the cases and controls, underwent tear collections using Schirmer strip. So what we do is we first store these strips in minus 80 degrees storage. Once we extract the tears from the Schirmer strip, we make it undergo through a process of what is called cytometric bead array analysis and multiplex ELISA, where a total of 26 annulates were measured. What did we find? We had extremely interesting observations where we found that there was a higher concentration of inflammatory factors in the tear fluid of corneal dystrophy patients. As you see, there's a significant difference. The most important marker that we found was raised interleukin-2. Now, we all know that interleukin-2 is responsible for T cell activation, which is an important pathway to kickstart the inflammatory pathway. In epithelial corneal dystrophies, we found higher levels of interleukin-1 alpha, interleukin-8, MCP and RANTES, which are all important markers for prolonging the inflammation. We also found extremely novel finding of L-selectin and P-selectin values being raised, and ICAM1 and VCAM1, which we know are adhesion molecules which are responsible, which are present on the epithelia of the corneal epithelium and are responsible for starting the inflammatory cascade. So can these be responsible for dysregulated healing response of corneal epithelium? In case of epithelial corneal dystrophy, we know we have recurrent abrasions, etc. In stromal dystrophies, we again found raised levels of interleukin-2, 4, TGF-beta, and when we compared these versus controls, we also found higher levels of fractalin, which we prophesize can be a possible modulation of the macrophages and dendritic cells in the diseased cornea. Fuchs endothelial dystrophy, we found extremely novel two findings. One, decreased levels of interleukin-17 and raised levels of TGF-beta. Now, both of these can be responsible for the aberrant production of extracellular matrix proteins, which could be responsible for Gaucher formation seen in Fuchs disease. Another very novel finding was decreased levels of angiogenin, which is a growth factor. So to summarize my findings, well, we found raised levels of interleukin-2 overall in all corneal dystrophies and interleukin-1 and interleukin-8. These can be used as a prime addition diagnostic candidates for diagnosis and treatment. Raised levels of ICAM1, VCAM, and TGF-beta expression across stromal and epithelial dystrophies. We can use targeted therapeutics to retard the opacification process. And I just already mentioned the Fuchs endothelial dystrophy. We have decreased interleukin-17 and raised TGF-beta. So how do we apply this? What is the practical application of this? Well, we all must have heard about ripasudil, which is a Rho kinase inhibitor, being used as a targeted approach for corneal endothelial cells in Fuchs dystrophy. The pilot studies are underway, but can we use anything else, something simpler that can be made available to our clinics? So based on our previous work in keratoconus, where we first proved that it is driven by an inflammatory pathway and that elevated expression of MMP9 can be inhibited by cyclosporin, we have been using cyclosporin to successfully treat the inflammatory milieu in keratoconus, and we have found that many and other targeted therapeutic approaches, we have found that it has brought about the stabilization of many early grade keratoconuses. So this is where the practical application of my study comes in. We propose a targeted drug delivery system for the treatment of corneal dystrophies. Well, we know that lifitegrast is an approved, FDA approved treatment for dry eye, where it blocks the adhesion of LFA1 to ICAM1. So we propose that in epithelial and stromal dystrophies, we could try and use lifitegrast. Because we found laced interleukin-2, cyclosporin could also be used as one of the first lines of medical management. And raise TGF-beta and FACT and decrease angiogenin. Well, we found literature where there is already something called recombinant klingle of human plasminogen, which is being used for treatment of endothelial wounds in Fuchs dystrophy. So this can also have application and prognostication. Well, when we know that there are certain markers which are different in one particular kind of dystrophy, can we use, say, for example, analysis of TGF-1 beta expression to help predict the progression of the disease? My colleague just spoke about having a kit. Well, we can have a differential kit for corneal disease which detects the raised biomarkers in the tears, and this can help in bespoke treatment, prognostication, and novel drug delivery systems. So to conclude, well, we knew that corneal dystrophy are progressive disorders of the cornea caused by deposition of aberrant proteins, and many of these are linked to mutations. However, it's the first study to conclusively prove that tear fluid of corneal dystrophy patients showed significant and distinct levels of pro-inflammatory cytokines and growth factors. The potential role of inflammation must be kept in mind while considering the treatment modalities. Targeted drug delivery systems to dampen inflammation could be used as a prophylactic strategy in retarding the progression and improving graft outcomes. Targeted therapeutics along with the use of a biomarker kit can be used for early detection, treatment, and predicting progression.